Hi friends, very good morning to all of you. I am Dr. Pankaj Tikku. I am your pediatric faculty at eGurukul, and I'll be taking your post intern classes on pediatrics. We'll be covering pediatrics in 4 days. And in 4 days, I believe I would be covering all the important topics which I think are relevant from your examination point of view, which I believe are the topics which are the high yield topics from which questions are asked in the exams. So this is the primary aim. We'll be covering pediatrics in these 4 days. Good morning to everyone. I hope I'm audible, visible to everyone. So we'll be starting pediatrics, but before I actually start pediatrics, I'll take just 5 minutes to tell you how to study pediatrics. This is a subject which now you know has increasing weightage in the next exam. So what used to be around, I think, 10 to 15 questions in the past, now we are likely to have around 60 questions from pediatrics. So it becomes a very, very important part of your examination, and therefore clearing pediatrics, I think, can help you sail through your NEET, PG or the next exam. So it's very, very important for you. Pediatrics was always an important chapter, always an important subject, but now I believe it is all the more important to get as many questions as you can possibly get right in pediatrics, because this is now a very, very important part of your exams. You must have seen the weightage. You'll be having around 60 questions from pediatrics alone, which makes it a very, very important topic. So believe me, if you are able to answer maximum number of questions from pediatrics alone, I think it can help you sail through your NEET PG or the next exam. So that makes this now a very, very important subject. It was already an important subject. It makes it now an even more important subject. And I'll help you answer most of those questions in the exams when they come. If you make your notes properly in the next 4 days, make your notes properly, are concentrating to whatever I'm saying, and are writing all those important points which I want you to write for your notes. Very important thing to know is that one student gets rank 1 in the exam, another student gets rank 100 in the exam, and there is another student who gets rank 1000 in the exam, there is another student who gets rank 10,000 in the exam, and there is another student who couldn't clear the exam. All of them, please remember, had the same amount of time, 24 hours. But how they utilize that time is very, very important. So unlike what we believe that time is very short, it's actually not time, but the focus, which is, according to me, the most important. How you are utilizing the time. Everyone who is going in for the exams has the same amount of time. The person who clears the exam doesn't have more time in comparison to you. If you will clear the exam, you will have the same amount of time as a person who was not able to clear the exam. But you have optimally utilized the time. And that person possibly did not know how to focus and therefore could not utilize that time properly. So it's very, very important for you to know that what is the focus in these exams. For pediatrics, how should I optimally utilize the same amount of time as all the others? Now, for that, it is very important for you to know an approximate weightage that each chapter of pediatrics carries for these exams. So based upon the previous year questions that I have seen, this is a very rough guide weightage which I have tried to calculate from the previous year questions. I've seen the last 7 to 8 years questions, and I've tried to create a weightage based on percentages as to which are the important topics. I believe that if you put a little more focus, I'm not saying do not put focus on the slightly lesser important chapters, but if you put the same amount of time, if you put a slightly more focus on the chapters which specifically I've highlighted in yellow, that includes malnutrition topic, very, very important topic, carries, according to me, almost a 15% weightage for your exams. Neonatology, I mean, it underscores the fact writing 20% of the questions are likely to be from neonatology, 20% questions of pediatrics are likely to be neonatology questions, underscores the fact that neonatology, according to me, is possibly the most important chapter. You are likely to have at least 2 questions every year from neonatology, and therefore this makes the neonatology chapter a very, very important chapter for your examination point of view. Cardiology, again a 15% weightage from cardiology. Congenital heart diseases, links of congenital heart diseases, their x-rays, the typical x-rays, syndromes and different congenital heart diseases. Very, very relevant. You have every year questions in which an x-ray is given. You are asked this congenital heart disease, this x-ray is pointing towards which possible congenital heart disease. So egg on string appearance, box-shaped heart, boot-shaped heart, snowman's heart, sign of 3, all of them are very, very important. It's important to identify those x-rays to be able to make your diagnosis from those x-rays. And you are through. Please also pay a lot of attention on neurology. Over the last 4 to 5 years, I've seen a lot of questions being asked from neural tube defects, seizures, especially seizures, both childhood seizures, neonatal seizures. Then a lot of questions asked from meningitis, then a lot of questions being asked specifically from neurocutaneous syndromes, Sturge-Weber syndrome, tuberous sclerosis specifically. These are the 2 main important neurocutaneous syndromes which we should focus on. Infections, a lot of questions asked on pediatric infections. I'm sure you all already know how important infections are for pediatrics. But infections, a lot of questions are being asked, including congenital infections. You often get 1 congenital infection every exam, be it congenital CMV, be it congenital toxoplasmosis, be it congenital rubella. So all of these again are very relevant. So what I'm trying to say, please try to appreciate the fact, what I'm trying to say. I'm trying to say that everyone has the same time. It's how you are utilizing the time which is important. Someone had told me something which is very, very relevant, and I remember that thing even today. I mean, I know it's very important to study, but more important is how to study, what to study, how to study, and when to study. These are 3 important things. But if you know how to study, if you know what to study, you are knowing what to study, which is there in front of you. And if you are able to spend at least around 5 to 6 hours daily with these important topics, I think pediatrics is done in 3 days. And if pediatrics is done in 3 days, 1 more revision before your exams, you are through. And you can put me in front and say that, sir, you had said that we'll be through if we give 2 revisions, focus on these important topics, and unfortunately we are not through. You can put me in front. That will never happen. Again, I'm repeating, this is not to say that the other topics which I've mentioned are not important. They are always important. Any topic from pediatrics is important. But the important thing is that if I have the same amount of time as others, how should I better utilize the time, the same amount of time in comparison to others? And believe me, those who are able to utilize the same amount of time in a better way are able to clear the exams. You all are people who have cleared your PMT exams. So, I mean, I do not see much difference between all of you. Some may be 51%, others may be 49%. You have all cleared. You should first identify your potential. You were the person who cleared your PMT exams when there were lakhs of students who gave the PMT exams. You were the cream who were able to clear those exams. So you have to identify your potential and remember that now when the same cream is giving the exams, the same top people are giving the exams, how should I clear these exams? Why does a certain group of students clear the exams, get much better ranks in comparison to others who put the same amount of hard work but unfortunately could not get through? It was possibly because although they put a lot of hard work, they did not put the hard work in the right direction. There are many people who say that what to eat is very important, but much more important is when to eat, how to eat. Similarly, what you study is very important, very, very important. And if you study that part in the limited period of time that you have, I think the results will be there. Regarding the method to study pediatrics, well, I have always followed this method, and if you follow this method, I think pediatrics will become very, very easy. So when I start with any chapter or any topic in pediatrics, first just go through the MCQs. Students normally go through the MCQs after they have read a chapter. I would recommend that you first go through the MCQs before starting with a chapter, before starting with your textbook, so that you are able to identify that when I'm reading the chapter, what are the questions and from which topics the questions have been frequently asked. So you will know, if you have first gone through the MCQs and then to the chapter, you will know in that chapter from where the MCQs have been frequently asked. You are able to identify those important chapters. MCQs are very, very important, and at least 30 MCQs, I would say, a day is a minimum. You can keep on increasing to around 40 after 10 days, 50 a day after another 10 days. But starting with 30 MCQs in a day is very, very important. Please remember, new MCQs are not formed usually. You have the same question bank, same topics, which are molded and presented in a different way. So topics remain the same. It may be NEET, it may be next. Topics remain the same. It's how they present that topic, how they ask questions from that topic, which may slightly, now you may have slightly more clinically oriented questions in comparison to less clinically oriented questions, the one-liners which were there in the past. But the topics remain the same. If you are able to identify the important clues from those questions, those cases, if you are able to identify the clues, you will be able to answer the question. You just have to identify the clues. So promise yourself 30 questions daily. Then once you have gone through those MCQs and you know those previous year MCQs, what those MCQs are, try to prepare a last minute revision point from those previous year MCQs. So for example, most common congenital heart disease seen in infant of diabetic mothers, and they have given 4 choices. And they have given one answer is, the answer to this question is VSD. So write down the most common congenital heart disease in infants of diabetic mothers, VSD. Then there is somewhere another question. The most common infection that is known to cause neonatal meningitis in India. It was a previous year question. There 4 options are given. The answer given is, say, E. coli. So now write down the most important cause of neonatal meningitis is E. coli. So make statements. Those statements will be your last minute revision point. So in a way you have completed all your previous year questions also. And you have also put those previous year questions in the form of your statements, which will be the last minute revision points when you will be going for your exams. No need to go through those MCQs again. So those will be your last minute revision points for your exams. Another thing, those MCQs that you have not been able to identify, not been able to answer, after you have gone through the chapter, you are answering MCQs once again. So first MCQ, then go to the chapter, read the chapter, then go back to the MCQs again answer all those MCQs. So there might be some 4, 5, 6 MCQs, which even after the second attempt, you are not able to identify. Those are the problematic topics which you should mark out in your notes. And those are the topics where specifically you should put more focus when you're doing the final revision just before your exams. No need to go through the whole chapter again. You don't have time at that time. So just identify those problematic topics where you found answering much more difficult, and just go through those problematic topics along with the last minute revision points that you have already written before your exams. That will make up your second or third revision. I would recommend 3 revisions, but obviously time is also very important. So 2 revisions are necessary. 1 revision you may do after the class, and the second revision before your exams. If you're able to give a 3rd revision, very good. If you're not able to give a 3rd revision, always keep your objective as minimum 2 revisions. And please always keep your focus on that problematic topics. It is not those topics which you could confidently answer, which will be the problem for you. It will be those problematic topics. I always found one of the problematic topics during the time when I was giving my exams. I always found one of the top problematic topics to be congenital heart diseases, and especially identifying cyanotic congenital heart diseases, the pathophysiology. So when I went for my exams, Congenital heart diseases, I'd already made those last minute revision points. I just put a little more focus on cyanotic congenital heart disease. And believe me, at that time, though that year, there were 2 questions asked from congenital heart disease. One of them was on cyanotic congenital heart disease. Lucky for me, and I was able to answer it correctly. And 1 question, correct answer, you know the importance of that. It can make or break a rank. So if you, again I'm repeating, if you go through these topics the way I'm suggesting you, at least in pediatrics, you can choose how to go through those other topics in the other subjects. But at least in pediatrics, if you follow the system that I am telling you, I don't think there should be a problem in covering pediatrics, and you can just answer put any query to me. We are always there to help you out. Premier group, Telegram group, and I also have a Telegram group of my own. I'll send you the link. You can join that Telegram group, and any query that you may have at any point of time, please feel free to put forward that query to. We are always here to help you out in this journey. This is the most important journey, I think, for your future, and you should mark this journey, start this journey in a very confident manner, and I'm sure you'll complete this journey with flying colors. And believe me, you can have my words for that. You have our backing for that. Please remember, we are always there to help you out. For pediatrics, I'm always there. Premier group, Telegram group, Facebook, or you can join my own Telegram group. I'll send you the link on this group, and you can join that group, and anytime you have any problem, morning, evening, night, day, you can always send that, and it will be answered within 24 hours. So with this, I hope you have understood the important, relevant things which I wanted to tell you how to study pediatrics. With that, I wish you all the best for your exams. I know it should be said after I've completed my classes, but I would start my classes by first telling you how to study pediatrics, which I've already told you, and then wishing you all the best for your exams. Please study the way I have told you, especially pediatrics, and you can see the difference. And now let us start with the first chapter, which is growth and development in children. This is an introductory topic of pediatrics, and as you saw, I gave 5% weightage to this. That 5% weightage is mainly on the milestones, which are often asked in the exams, so a very important, relevant topic for your exams. But let us start now. Growth and development. Now, when a child is delivered, the child passes through various stages of growth, and each of these have been given a different name. The first 28 days of life, the child is called as a neonate or a newborn. So if someone asks you, who is a neonate is a child who is in his first 28 days of life. Then the child in his first year of life is called as an infant. So who is an infant? An infant is a child who is in his first year of life. So any child below 1 year will be called as an infant. A child between 1 to 3 years is called as a toddler. So who is a toddler? A toddler is a child who is between 1 to 3 years of age. A child who is between 3 to 6 years of age is considered to be in his preschool age group. So who is a child who is in his preschool age group? A child who is between 3 to 6 years of age. Then a child between 6 to 12 years is known to be in his school age group. And finally, adolescence is a period between 10 to 19 years of age. This is the name which has been given to the adolescent period by the World Health Organization. So repeat with me, the first 28 days of life, the child is called as a newborn or a neonate. First year of life, the child is called as an infant. 1 to 3 years, the child is considered to be a toddler. 3 to 6 years, the child is considered to be in the preschool age. 6 to 12 years, the child is considered to be in the school age. And 10 to 19 years, the child is considered to be an adolescent. So if someone asks you who is an adolescent is a child who is between 10 to 19 years of age. So repeat with me once again. First 20 days neonate, first year infant, 1 to 3 years toddler, 3 to 6 years preschool age, 6 to 12 years school age, and 10 to 19 years adolescent age. Now there is a question that is often asked, what is the difference between adolescence and puberty? What's the difference between adolescence and puberty? So as I have just now told you, adolescence is actually an age group. It's actually an age group which corresponds to 10 to 19 years of age. So adolescence starts from 10 years and continues till 19 years of age. In that age group, when the sexual characters they start developing, this is known as puberty. So what is puberty? Puberty is the development of sexual characters. Pubic hair development, axillary hair development, breast development, gonadal development. So puberty is the development of sexual characters. In which age group? In the adolescent period. So these terms should not be used interchangeably. They are different terms. Adolescence is an age group, and puberty is the development of sexual characters in that age group. So just repeat with me. First 20 days neonate, first year infant, 1 to 3 years toddler, 3 to 6 years preschool age, 6 to 12 years school age, 10 to 19 years adolescent age. And what's the difference between adolescence and puberty? Adolescence is an age group. Development of sexual characters in that age group is called as puberty. So there is a separate Telegram group for pediatrics, which is my own group, which I will give you the link. If you want to join that group, you can join that group. Otherwise, you can post your questions in this group only. Okay, now coming to the sequence of puberty. So I told you what is puberty. Puberty is the development of sexual characters. In which age group? In the adolescent period. Now, as you must be knowing, you have already had your classes from physiology. You already know that hypothalamus. So hypothalamus, it secretes the gonadotropin releasing hormone. And this secretion of gonadotropin releasing hormone from the hypothalamus starts just before the onset of puberty. So if puberty starts from the age of around 10 years, adolescence and puberty starts from 10 years, the secretion of gonadotropin releasing hormone starts just before the onset of puberty. So from around 7 to 8 years of age, there is a pulsatile secretion of gonadotropin releasing hormone from the hypothalamus, which stimulates the pituitary, the anterior pituitary, to secrete the gonadotropin, so the luteinizing hormone and the follicle stimulating hormone. The luteinizing hormone and the follicle stimulating hormone, they start getting secreted under the action of the gonadotropin releasing hormone. And because gonadotropin releasing hormone is being secreted in a pulsatile fashion, similarly, the luteinizing hormone and the follicle stimulating hormone, which are also called as gonadotropins, they are secreted in a pulsatile fashion. So you have peaks that occur during the night time when the levels are at the highest, and there are troughs which occur during the daytime. So luteinizing hormone peak during the night time, nocturnal surges, and then there are troughs during the daytime. If you are asked a question, which is a better measure of the pubertal status out of luteinizing hormone and follicle stimulating hormone, which is a better measure or a better marker of puberty? It is the luteinizing hormone. So luteinizing hormone is a better marker of the pubertal status, better marker of puberty compared to the follicle stimulating hormone. And both of them are called as the gonadotropins. And these gonadotropins, which are secreted in a pulsatile fashion, they stimulate the gonads to release the gonadal androgens, which includes the testosterones and the estrogens. And the secretion of both of them starts just before the onset of puberty. So now the pubertal status is being prepared by this hypothalamic pituitary gonadal axis. What is this axis called? Hypothalamic pituitary gonadal axis. So gonadotropin releasing hormone stimulating the pituitary to secrete the gonadotropins in a pulsatile fashion. And the pituitary gonadotropins, which are LH and FSH, secreting or stimulating the gonads to secrete the estrogens and the testosterones. And it is these estrogens and testosterones which help in the development of the pubertal signs. So they mark the onset of puberty. Out of the two gonadotropins, which is a better marker of pubertal status or puberty, it is luteinizing hormone, which is a better marker of puberty. A very, very important question for your exams. So out of LH and FSH, which is a better marker of puberty, it is LH, luteinizing hormone. So which are the main hormones which are involved in the development of puberty? It is these gonadal androgens, the testosterones and the estrogens. But at the same time, there are also certain androgens which are secreted by the adrenals. So the adrenal gland, as you know, has two parts, the adrenal cortex and the adrenal medulla. So there are certain adrenal cortex androgens which are secreted from the adrenal cortex, and they also stimulate the gonads, resulting in the development of puberty. So main hormones which control puberty is testosterones and estrogens, but there is also secretion of certain C19 androgens from the adrenal gland, which contribute at least partly to the development of puberty. So puberty mainly under the control of estrogens, testosterones, partly under the control of the C19 androgens. And which is the main hormone circulating in the circulation, the most important among them? So the most important among them is DHEAS, dihydroepiandrosterone sulfate. Dihydroepiandrosterone sulfate. This is the most important and the most abundant C19 adrenal androgen in the circulation. So if you are asked this question, which is the most abundant C19 androgen, the androgen secreted from the adrenal glands, which is the most important C19 adrenal androgen or the most abundant C19 adrenal androgen in the circulation, it is dihydroepiandrosterone sulfate, DHEAS. So androgens also play at least a contributory role, if not the main role, in the development of puberty. The main role played is by the testosterones and estrogens. But there is a contributory role from the adrenal androgens, and which is the most abundant adrenal androgen. The most abundant adrenal androgen is dihydroepiandrosterone sulfate. So just a quick recap. Just before the onset of puberty, which is somewhere around 7 to 8 years of age in children, there is secretion of gonadotropin releasing hormone from the hypothalamus in a pulsatile fashion. This stimulates the pituitary, the anterior part, to secrete the gonadotropins, luteinizing hormone and follicle stimulating hormone. Among the two, which is the better marker of pubertal status or puberty? It is luteinizing hormone. These gonadotropins stimulate the gonads to release the testosterones and estrogens, which are the main hormones responsible for the puberty development. However, there is also a contributory role played by the androgens secreted from the adrenal glands, adrenal cortex. Most of these androgens from the adrenal glands are C19 steroids, C19 androgens. And the most abundant in the circulation among the C19 androgens, which has been asked as a question in the exam, is dihydroepiandrosterone sulfate, DHEAS. So these hormones are contributing to the development of puberty. And when puberty develops, they do not develop, all the pubertal signs do not develop together. They develop in a sequence. Please remember, puberty starts from the age of 10 years in girls, and puberty starts from the age of about 11.5 years in boys. So girls enter into puberty about 1.5 years earlier than boys. Girls enter into puberty by the age of around 10 years, while boys enter into puberty by the age of around 11.5 years. The first sign of puberty in girls is thelarchy, breast development. So breast development is the first sign of puberty in girls. This is followed by the development of pubic hairs. So pubic hair development, which is called as pubarchy, which is followed by a sudden acceleration in growth velocity in children, which is called as the peak growth spurt period. So growth is occurring throughout childhood, but there is a sudden acceleration of growth velocity, which is called as peak growth spurt period. And then this is followed by the last sign of puberty in girls, which is menstrual cycle, so menarche. So repeat with me, what are the sequence in which the pubertal signs develop in girls? Thelarchy, breast development; pubarchy, pubic hair development; sudden acceleration of growth velocity in children, which is called as the peak growth spurt period, followed by the menstrual cycles, which marks the end of puberty in females. Thelarchy, pubarchy, peak growth spurt, menarche. In boys, the first sign of puberty is increase in the size of the testis. So the increase in the size of the testis is the first sign of puberty in boys, which starts at the age of about 11.5 years. And this is followed by the development of pubic hairs, which is called as pubarchy. Again, acceleration of growth velocity, which is called as the peak growth period. And this is followed by the growth of the facial hairs, which is beard, and also the development of sperms, which is called as spermarchy. So repeat the sequence of pubertal signs in boys: increase in the testicular size, followed by pubarchy, pubic hair development, followed by peak growth spurt, and this is followed by the last sign of puberty in boys, which is the growth of the facial hairs, beard, and spermarchy. So sequence in girls: thelarchy, pubarchy, peak growth spurt, menarche. Sequence in boys: increased testicular size, pubarchy, peak growth spurt, growth of the beard, and spermarchy. Now, just a few words about the peak growth spurt in children. See, growth occurs throughout the childhood period. So starting from the intrauterine life, when the child is called as a fetus, intrauterine life, to the child born, which is the neonate, then infant, then toddler, then preschool age, school age, adolescent. Throughout the intrauterine and childhood period, the child is growing. But there are two periods of growth when there is a sudden acceleration of growth velocity. So they are called as peak growth spurt periods. The first period is the intrauterine life plus the first year of life when the child is called as an infant, and the second time when the growth suddenly accelerates is in the adolescent period. So these are two important periods of peak growth spurt in children. First, intrauterine life, when the growth of the child is very, very fast. And this rapid growth continues even after the child's birth, first year. Then after the first year, please try to understand the growth of the child starts to deaccelerate, slows down. So whatever weight, height the child was gaining in the first year, the child will gain less amount of weight, less length increase in the second year. Lesser weight, lesser length increase in the third year. Lesser weight, lesser length increase in the fourth year. So this deacceleration will continue till the time the child enters into the adolescent, when the second peak growth spurt will occur. So two times the peak growth spurt has occurred, the intrauterine life and infant and the adolescent period. If I break down the first period of the peak growth spurt, intrauterine and infant, into two separate parts. So now I have three parts when the growth of the child is very, very rapid. Three parts of peak growth spurt. First, intrauterine life, second infant, and third is adolescent. Now, if I ask you to arrange these three periods in their order of growth velocity, these three periods of growth spurt, how will you arrange them? Is intrauterine the fastest? Is infant phase the fastest, or is adolescent phase the fastest? Out of these three peak growth spurt periods, the fastest will be intrauterine life, followed by infant, followed by adolescent. So mark them or arrange them in their order of decreasing growth velocities. Mark them in the order of decreasing growth velocities. Whatever I'm writing MCQs, that means that it has been asked previously in the exams. So arrange these three peak growth spurt periods in their order of decreasing growth velocities. So the fastest is intrauterine life. This is followed by infant period. And this is followed by the adolescent period. Out of the three peak growth spurt periods, fastest is intrauterine life, which is followed by the infant, which is followed by the adolescent period. So this is how you have arranged them in their order of peak growth spurt: intrauterine life, infants, and adolescent period. So I hope you will remember these for your exams. Coming now to another important topic. How do you evaluate growth in children? How do you evaluate growth in children? Now, growth is evaluated by means of certain markers of growth assessment. And you have in front of you markers of growth assessment. So the markers of growth assessment are weight of the child, length or height of the child, head circumference of the child, and mid-arm circumference of the child. So these are the four important markers of growth assessment: weight of the child, height of the child, head circumference of the child, and the mid-arm circumference of the child. Let us study them one by one. First, let us go to weight of the child. Now, as you must be knowing very well, whenever a child is born, the child has a certain weight. And this weight is called as the birth weight. All newborns, they lose some weight in the first few days of life. And it's a universal phenomena. All newborns, they lose some weight in the first few days of life. How much weight is considered or how much weight loss is considered physiological depends upon whether the child is a term child or a preterm child. So term children, they lose about 5 to 10% of the birth weight, and preterm children will lose about 10 to 15% of the birth weight. So till the time the loss of birth weight is 5 to 10% in terms and 10 to 15% in preterms, it is considered physiological. But if the weight loss is more than this, then this is definitely pathological. So see here, the child has a weight which is known as the birth weight. Now there is some loss in weight in the first few days, and after that the weight of the child starts increasing again. So after a certain loss in weight, the weight of the child starts increasing again. So when do children regain their birth weight? So terms, they lose about 5 to 10% of the birth weight and they regain their birth weight by day 10. And preterms, they lose slightly higher amount of weight, which is 10 to 15% of the birth weight, and they regain their birth weight by day 14. So by day 10, term children regain their birth weight, and by day 14, preterm children regain their birth weight. And after that, how much is the weight of a child? You can calculate the normal weight of a child if you know the birth weight. What did I say? If you know the birth weight of the child, you can calculate the approximate weight of a child at any age. How? How? Double the birth weight at 5 months. 3 times the birth weight at 1 year. 4 times the birth weight at 2 years. 5 times the birth weight at 3 years. 6 times the birth weight at 5 years. And 7 times the birth weight at 7 years. So the birth weight of a child becomes double the birth weight at 5 months, becomes 3 times the birth weight at 1 year, becomes 4 times the birth weight at 2 years, becomes 5 times the birth weight at 3 years, becomes 6 times the birth weight at 5 years, and becomes 7 times the birth weight at 7 years. Repeat with me. Double the birth weight, 5 months. 3 times the birth weight, 1 year. 4 times the birth weight, 2 years. 5 times the birth weight, 3 years. 6 times the birth weight, 5 years. And 7 times the birth weight at 7 years. I'll repeat again. Double the birth weight, 5 months. 3 times the birth weight, 1 year. 4 times the birth weight, 2 years. 5 times the birth weight, 3 years. 6 times the birth weight, 5 years. And 7 times the birth weight at 7 years. I would recommend you, please, people, write down with me and repeat with me. That's the best way to remember. For all images which are there in my classes, any image, any table that I will use, I will send you the images and table PDFs. Do not worry. But the remaining things I would recommend, please write down. I am never in favor of sending whole PDFs because that makes a person very relaxed. And as I told you, this is not the time to feel so relaxed. You have to prepare your notes. You have to repeat with me. If you are repeating with me the things that I'm talking in the class, if you're preparing your notes with me, I can guarantee you that you will be through these exams. You can, at least for pediatrics, I can guarantee you'll be able to answer maximum number of questions. So please just repeat things with me. You are sitting in your home, or you are sitting in your center where you are studying. Please repeat with me, write down, prepare your notes. Preparing notes always help to go things in your head. As for the images, as for the graphs, as for the tables, do not worry about them. I will send those image PDFs to you at the end of the classes. Do not worry about that. But it's a sincere request to you. If you want to remember the things and things go into your head, please request, please repeat with me and make your notes. Without making notes, it's as good as a book. You have a better book for you, which is OP Ghai. You have to make your notes yourself. Unless and until you make your notes, you will never be able to remember the things for your exams. So, weight of the child, loss of 5 to 10% of the birth weight in a term child, loss of 10 to 15% of the birth weight preterm child. Term child regain their birth weight by day 10, preterm child regain their birth weight by day 14. If you know the birth weight of the child, it becomes double the birth weight at 5 months. It becomes 3 times the birth weight at 1 year. It becomes 4 times the birth weight at 2 years. It becomes 5 times the birth weight at 3 years. It becomes 6 times the birth weight at 5 years. And it becomes 7 times the birth weight at 7 years. Coming to length. Length is always calculated. Length is always assessed till the age of 2 years in children, while height of the child is always assessed after the age of 2 years in children. So till 2 years, you assess the length. After 2 years, you assess the height. So till what age group do we assess the length of children? We assess the length of children till the age of 2 years. And after what age do we assess the height of children? We assess the height of children after the age of 2 years. The length of children is measured by means of an instrument which is known as an infantometer. But the standing height of children is measured by means of an instrument which is known as a stadiometer. So infantometer is used to measure the length till 2 years of age. And stadiometer is used to measure the standing height after 2 years of age. You had this NEET PG question where they asked an alternative method to measure the standing height of the child. Alternative method to measure the standing height of the child. And that alternative method to measure the standing height of the child is known as an arm span. So not a very reliable method. The most reliable method to measure the standing height is a stadiometer. But arm span in children can be used as an alternative method to measure the standing height. You make the child stand against the wall with arms wide apart and take the distance from the tip of the middle finger on one side to the tip of the middle finger on the other side. So this is known as an arm span. Please remember, the arm span is always less than the standing height, below 10 years. So any child who's below 10 years, arm span is always less than the height. So when does the arm span becomes equal to the height? When does the arm span becomes to the height? Arm span becomes equal to the height at the age of 10 years. So when does the arm span becomes equal to the standing height? The arm span becomes equal to the standing height at the age of 10 years. So arm span is never a very reliable method. Arm span is not a very reliable method. Arm span only is an alternative method to measure the standing height. Which is the more reliable method? The more reliable method is the length, which is, the more reliable method is an infantometer for measuring length till 2 years and stadiometer for measuring the height after 2 years. Now, what is the length of a child at birth? The length of a child at birth is 50 centimeters. The length of a child at birth is 50 centimeters. It becomes 75 centimeters at the age of 1 year. Becomes 85 centimeters to about 90 centimeters at 2 years. And then between 2 to 12 years, there is an increase in the height between 2 to 12 years of age. This question has been asked in the exam, so it's a previous year question. How much height increases in children between 2 to 12 years of age? The height increase in children between 2 to 12 years of age is approximately 6 centimeters every year. So it was 50 centimeters at birth. It becomes 75 centimeters at 1 year. It becomes 85 to 90 centimeters at 2 years. And between 2 to 12 years, it increases at the rate of 6 centimeters every year. And then obviously in adolescence, as I told you, there is a growth spurt. How many growth spurt did I told you? Peak growth spurts, 3 peak growth spurts. Actually, one growth spurt which is combined, intrauterine and infancy. So if you divide it into 2, infancy 1, intrauterine 1. And the other peak growth spurt period is the adolescent. So adolescent peak growth period is the second peak growth period after the first peak growth period, which is infancy and intrauterine life. So this is how the length of the child increases. Repeat with me. 50 centimeters birth, 75 centimeters 1 year, 85 centimeters to 90 centimeters 2 years, and then between 2 to 12 years, 6 centimeters every year. Coming to head circumference of the child. This is the third growth assessment parameter. So after weight of the child, after height of the child, then the third is the head circumference of the child. What is the head circumference of a child at birth? The head circumference of a child at birth is about 35 centimeters. So this is the head circumference of a child at birth, about 35 centimeters. It becomes 40 centimeters at 3 months. It becomes 43 centimeters at 6 months, and it becomes 46 centimeters at 1 year. Remember like this: 35, 40, 43, 46. Birth, 3 months, 6 months, 1 year. Birth, 3 months, 6 months, 1 year. 35, 40, 43, 46. So what is the head circumference at birth? 35 centimeters. What is the head circumference at 3 months? 40 centimeters. What is the head circumference at 6 months? 43 centimeters. What is the head circumference at 1 year? 46 centimeters. 35, 40, 43, 46. Birth, 3 months, 6 months, 1 year. Repeat with me. At birth, what is the head circumference? 35 centimeters. At 3 months, what is the head circumference? 40 centimeters. At 6 months, what is the head circumference? 43 centimeters. At 1 year, what is the head circumference? 46 centimeters. So as you can see, an increase of almost 10 to 12 centimeters in the head circumference in the first year only. So in the first year only, the child's head circumference increases by about 46 centimeters, starting from about 34 centimeters at birth to almost 46 centimeters at 1 year. So it is 12 centimeter increase in head in the first year. And just see how much head increases in the second year. Only 2 centimeters. So what is the time when the head circumference is growing the fastest? It is in the intrauterine life and in the first year of life. Very, very rapid growth of the brain. So that is why we say, what do we say? We say children follow a cephalocaudal growth. So what is the sequence of growth in children? What is the sequence of growth in children? The sequence of growth in children is cephalocaudal. Cephalo means head, caudal means toes. So initially it's the head which is growing very fast. Then the child's trunk starts growing fast. And then the child's legs, extremities start growing fast. Cephalocaudal, distal, proximal. So cephalocaudal, distal, proximal. Cephalocaudal, distal, proximal. Cephalocaudal, distal, proximal. This is the sequence of growth. Cephalocaudal, distal to proximal. So head circumference is growing very, very rapidly during the intrauterine life and first year, after which it slows down. So when a child is born, at birth, the head circumference is much more than the chest circumference. CC is chest circumference. HC is head circumference. So at birth, the head circumference of the child is more than the chest circumference because the head is growing very, very fast. So when does the two become equal? So the head circumference becomes equal to the chest circumference by the age of about 1 year. So this again is a very important MCQ. When does the head circumference of a child becomes equal to the chest circumference? So the head circumference of a child becomes equal to the chest circumference by the age of about 1 year. Cephalocaudal, distal to proximal. Cephalocaudal, distal to proximal. This is the sequence of growth in children. Cephalocaudal, distal to proximal. So there is a question, an infant can stand after 1 year, then why measure height? So it's a very good question, but please remember, all infants are able to stand at 1 year, but there is a physiological bowing of legs which is present in most infants at this stage, physiological bowing. So they will never be able to stand erect. They can stand, but they can never stand erect because of physiological bowing of legs. And this physiological bowing of legs disappears by 2 years. That is why it's always better to measure the height after 2 years, length till 2 years. A very good question. A child can stand at 1 year, then why not take height after 1 year? Because although the child can stand, the child cannot stand erect at 1 year. And reason why the child cannot stand erect at 1 year, physiological bowing of legs which is present in these children, which disappears by 2 years of age. That is why always measure the height after the age of 2 years. I hope I've answered this question. The last growth assessment parameter in children is the mid-arm circumference of the child. So mid-arm circumference of the child is the last growth assessment parameter that we will study. It's a age independent marker of growth assessment. You don't need to tell what is the age. If I tell you the mid-arm circumference of a child is more than 13.5 centimeters, the child is a normal child. Mid-arm circumference is not age dependent. Just telling mid-arm circumference more than 13.5 centimeters is just good enough to say that the child is normal. Age dependent markers are weight, height, head circumference. But mid-arm circumference is an age independent marker and usually measured between 1 to 5 years of age. It's usually measured between 1 to 5 years of age. Actually, some people measure mid-arm circumference from 6 months onwards. So till 6 months, from 6 months onwards, you can still measure the mid-arm circumference, but it's more reliable if it is measured between 1 to 5 years of age. Below 6 months, definitely it should not be used. Above 5 years, definitely it should not be used for growth assessment. One of the methods to measure the mid-arm circumference. Now, normally mid-arm circumference more than 13.5 centimeter is considered as normal. So what is a normal mid-arm circumference in children? A mid-arm circumference of more than 13.5 centimeters is considered as normal. However, when you are using a Shakid's tape to measure the mid-arm circumference, then the normal value changes. So this is a 3-color Shakid's tape, which is often used to measure the mid-arm circumference of the child. This is also called as a 3-color Shakid's tape. Its total length is 26.5 centimeters. So what is the total length of a Shakid's tape? The total length of a Shakid's tape is 26.5 centimeters. So you wrap this tape on the arm, the mid portion of the arm, and measure the mid-arm circumference. Now, as you can see, there are 3 colors on one side. One is a green color, one is a yellow color, and one is a red color. So if the child's, now you can see here, this is an arrow, there is an arrow. So you pass the tape through this arrow, and depending upon whether this arrow is pointing towards the red color, yellow color, or the green color, you have different values of the mid-arm circumference of the child. So if this arrow points towards the red color, that means the mid-arm circumference of the child is less than 11.5 centimeters. If this arrow points towards the yellow color, that means the mid-arm circumference is between 11.5 to 12.5 centimeter. And if this arrow points towards the green color, that means the mid-arm circumference is more than 12.5 centimeters. So according to the Shakid's tape, a mid-arm circumference of more than 12.5 centimeters is considered as normal, while a mid-arm circumference less than 11.5 centimeters is considered as severe malnutrition, while a mid-arm circumference between 11.5 to 12.5 is considered as moderate malnutrition. So if someone asks you, what is normal mid-arm circumference according to the Shakid's tape? Normal mid-arm circumference according to the Shakid's tape is a mid-arm circumference of more than 12.5 centimeters. Severe malnutrition is mid-arm circumference less than 11.5 centimeters, while moderate malnutrition is mid-arm circumference between 11.5 to 12.5 centimeters. So this is a 3-color Shakid's tape with a total length of 26.5 centimeters. What about body mass index? It is also age dependent. Yes, body mass index is also age dependent, but body mass index is not a growth assessment parameter. We are talking about growth assessment parameters. Body mass index basically can tell you whether the child is overweight, obese, normal, but it is not useful for evaluating the growth of children. But yes, it is age independent parameter. I am talking which is the best age independent growth assessment parameter. There it is mid-arm circumference. So let us just repeat once quickly so that you are able to remember the things for your exams, and please repeat with me. So which are the 4 growth assessment parameters? The 4 growth assessment parameters are length, weight, head circumference, and mid-arm circumference. First, what did we study about weight? Terms lose 5 to 10% of the birth weight, regain birth weight by day 10. Preterms lose 10 to 15% of the birth weight, regain birth weight by day 14. If you know the birth weight of the child, you can calculate the child at any age. So weight becomes double the birth weight at 5 months, 3 times the birth weight at 1 year, 4 times at 2 years, 5 times at 3 years, 6 times at 5 years, 7 times at 7 years. Length of a child measured till the age of 2 years and height of a child measured after the age of 2 years. Length measured by an infantometer, height measured by a stadiometer. Alternative method to measure the standing height is a arm span. Length of a child at birth 50 centimeters, 1 year 75 centimeters, 2 years 85 centimeters to 90 centimeters. Between 2 to 12 years, increase of length of about 6 centimeters every year. Head circumference increases more than the chest circumference initially because all children have a cephalocaudal growth sequence. Cephalocaudal, distal to proximal. So what is the growth sequence? Cephalocaudal, distal to proximal. Head circumference, how does it grow? Repeat with me. 35 centimeters, birth. 40 centimeters, 3 months. 43 centimeters, 6 months. 46 centimeters, 1 year. So 12 centimeter increase in the first year in head circumference and only 2 centimeters increase in the second year onwards. So head circumference growth slows down considerably after the first year of life. During the intrauterine life and first year, head circumference is growing very, very fast. Which is more at birth? Head circumference is more than the chest circumference at birth. The two become equal at the age of 1 year. Mid-arm circumference is a age-independent growth assessment parameter. It is measured between the age of 1 to 5 years. As I told you, can be measured between 6 months to 1 year also. But better to use it between 1 to 5 years. Never use it below 6 months. Never use it above 5 years for growth assessment. Normally, mid-arm circumference more than 13.5 centimeter is considered normal when you are using a steel tape or a fiber optic tape. So in our OPDs, we use a steel tape or a fiber optic tape to measure the mid-arm circumference. A steel tape or a fiber optic tape. So when you are using a steel tape or a fiber optic tape, a mid-arm circumference of more than 13.5 centimeter is normal. But when you are using a Shakid's tape, so specifically with a Shakid's tape, mid-arm circumference of more than 12.5 centimeter is normal. So there is a little discrepancy. If they ask you what is normal mid-arm circumference, your answer should be more than 13.5 centimeters. But if they specifically ask you what is normal mid-arm circumference according to Shakid's tape, then answer should be more than 12.5 centimeter. So when I'm using a routine steel tape or a fiber optic tape to measure the mid-arm circumference, a mid-arm circumference of more than 13.5 centimeter is normal. But when I'm using a Shakid's tape specifically, then a mid-arm circumference of more than 12.5 centimeters is normal. 4 things for your exams about Shakid's tapes. Total length 26.5 centimeters. Green color more than 12.5 centimeters normal. Yellow color between 11.5 to 12.5 centimeter moderate malnutrition. And less than 11.5 centimeter is severe malnutrition. So I think I've answered this. Mid-arm circumference more than 13.5 centimeter is normal normally. But if they specifically ask you in the exam, according to the Shakid's tape, mid-arm circumference more than 12.5 or 13.5 is normal, then your answer should be more than 12.5 according to Shakid's tape. Otherwise, if you are using a routine steel tape or a fiber optic tape, which we use in our outpatients, then more than 13.5 centimeter is considered normal. So I think I've answered it. If they just ask you what is normal mid-arm circumference, close your eyes and with confidence say more than 13.5 centimeters. But if they say in a community setting using a Shakid's tape, what is normal mid-arm circumference, then answer becomes more than 12.5 centimeters. A few words about abnormalities of the head size in children. So there are 2 types. We were discussing about head circumference. So there are 2 types of abnormalities which can be seen in the head circumference. One is when the head appears to be abnormally large. We call it as a macrocephaly or a large head. It is head circumference of a child more than 2 standard deviation from the expected. But another is a microcephaly or a small head when the head circumference is less than 3 standard deviation from the expected. So what is the definition of macrocephaly? Macrocephaly is defined as head circumference more than 2 standard deviation above the expected. So whatever you expect for the particular age, if the head circumference of a child is more than 2 standard deviation, and this can be only found out when you plot it on a growth chart. So then macrocephaly will be head circumference more than 2 standard deviation on a growth chart. And microcephaly will be head circumference less than 3 standard deviation on the growth chart. Now, what can be the important causes? UNICEF tape and the Shakir's tape are the same. Shakir's tape is also called as the 3-color UNICEF tape. So what are the important causes? What are the important causes of macrocephaly in children? Important causes of large head in children. So the important causes of large head in children can be remembered by a mnemonic: Helens 3H, Helens 3H, 2L, 1N, 1S. These are the important causes of macrocephaly in children. Helens 3H, 2L, 1N, and 1S. So the first H is hydrocephalus. The second H is hydrancephaly. And then the third H is hemorrhage. Hemorrhage in the brain. So the first, second and third H, hydrocephalus, hydrancephaly, and a hemorrhage. What is a hydrancephaly? I will tell you. But first, write down the causes. These are the causes of large head: hydrocephalus, hydrancephaly, and a hemorrhage. Hemorrhage in the brain. Any type of intracranial bleeding in a newborn baby can lead to an increase in the head size. It may be a subarachnoid hemorrhage. It may be a intracranial hemorrhage in the germinal matrix. Any type of intracranial bleeding in a newborn baby can lead to a head size because the sutures have not fused by this time. Hydrocephalus we'll discuss in detail when we will be doing neurology. Hydrocephalus is basically, so don't write about it. Hydrocephalus is basically an impairment of the flow of the CSF. So when there is an impairment in the CSF flow, for example, there is an obstruction inside the ventricles. Obstruction inside the ventricles. And CSF starts collecting inside the ventricles. So the ventricles start increasing in size. And when the ventricles start increasing in size, the head starts increasing in size. You can see this picture. This is a normal head. This is a normal head, and you can see the ventricle here. You can see this lateral ventricle. Just see the size of the lateral ventricle. Just see the size of the third ventricle. TV is the third ventricle. And now see what happens to these. Just see what has happened to the size of the lateral ventricle. What has happened to the size of the third ventricle. Just compare it. Just compare these two. And you can immediately see the lateral ventricle have massively increased in size. The third ventricle has increased in size. And this increase in size is possibly because somewhere an obstruction is happening inside the ventricles. So this collection of CSF leading to an increase in the ventricle size, leading to an increase in the head size, is called as hydrocephalus. Hydranencephaly, this is hydranencephaly. Hydranencephaly is an atrophy of the cerebral hemispheres. So hydranencephaly is atrophy of the cerebral hemispheres. So wherever the cerebral cortex is present, you can see the cerebral hemispheres in this first picture. You can see the cerebral hemispheres. CH is the cerebral hemispheres. So you can see the cerebrum. This has atrophied. So no cerebrum present in a hydranencephaly. So this entire space does not have a cerebrum. There is atrophy of the cerebral hemispheres, and this entire space gets filled up with CSF, which keeps on increasing in size because it is accumulating. CSF is accumulating. It is being produced. It is accumulating. It is leading to an increase in the size of the head, and therefore macrocephaly. So what is hydranencephaly? Hydranencephaly is atrophy of the cerebral hemispheres and increase in the CSF accumulation in this space, leading to increase in the head size. So whatever space cerebral hemispheres are present, that space is now empty. This space is filled up gradually with more and more CSF, which keeps on accumulating, and this leads to increase in the head size. What is this called? This is called as a hydranencephaly. Please don't confuse a hydrocephalus with a hydranencephaly. Hydrocephalus is increase in the ventricle size because of CSF collecting inside the ventricles. But hydranencephaly is atrophy of the cerebral hemispheres. That space gets filled up with CSF, and it's the CSF that keeps on accumulating and increasing in size, leading to enlargement of the head. As I told you, don't worry about images. I'll send you all images, all graphs, all tables which are used in this. Just focus on the images. Do not worry about them. So as you can see here, 3H, important cause of macrocephaly, are hydrocephalus, hydranencephaly, hemorrhage. Now 2L, which are the 2L, which are causes of large head. The first L is leukodystrophies, and the second L is lysosomal storage disorders. Lysosomal storage disorders. So leukodystrophies and lysosomal storage disorders, they are also important causes of large head. What is a leukodystrophy? Leuko means white. Leuko means white. And dystrophy means degeneration. Dystrophy means degeneration. White matter degeneration. So disorders associated with white matter degeneration. Myelin sheath degeneration. Myelin is white matter. So disorders associated with myelin sheath degeneration, they are called as leukodystrophies. And there are some leukodystrophies which can present with large head. All leukodystrophies will not present with large head. Metachromatic leukodystrophies, Alexander's disease, Canavan's disease, adrenoleukodystrophies, many type of leukodystrophies. But which are the two leukodystrophies associated with large head? One is Alexander's disease. The other is Canavan's disease. So these are the two leukodystrophies which are associated with large head. Alexander's disease and Canavan's disease. So if you are asked this question, can you name some leukodystrophies which are associated with the large head? Answer is Alexander's disease, Canavan's disease. So there is a question, why is mid-arm circumference used only till 5 years and not after 5 years? See, the reason is that we have available data on what is normal and what is not normal mid-arm circumference only till 5 years of age. After 5 years of age, children, we do not have the data for what is normal mid-arm circumference and what is abnormal mid-arm circumference. So when I do not have the data to tell what mid-arm circumference after 5 years is normal and what is not normal, what is the point of measuring the mid-arm circumference? All the data pertaining to mid-arm circumference, what is normal, what is mild, what is severe malnutrition, that all is till 5 years of age, between 1 till 5 years. After 5 years, we do not have the available data to tell what mid-arm circumference is normal. Therefore, it is better to use a mid-arm circumference only between 1 to 5 years, for which a strong available data is present to tell what is normal, what is not normal. That is why we use mid-arm circumference till 5 years of age. I hope the student who asked this question has understood this. So, leukodystrophies, lysosomal storage disorders. So there are some lysosomal storage disorders also which can present with the large head. Tay-Sachs disease, for example. So Tay-Sachs disease again is a disorder which can present with a large head. Then N. N stands for neurocutaneous syndrome. Neurocutaneous syndrome. So there are some neurocutaneous syndromes which can present with large head. Neuro means CNS. Cutaneous means skin. So those disorders which are associated with skin and CNS manifestations, those group of disorders are known as neurocutaneous disorders or neurocutaneous syndrome. You must have heard about neurocutaneous syndromes such as ataxia telangiectasia, Sturge-Weber syndrome, tuberous sclerosis, neurofibromatosis. The important neurocutaneous syndrome which can present with a large head, one of them is tuberous sclerosis. And we'll discuss about tuberous sclerosis when we will do neurology. So we'll discuss about this neurocutaneous disorder which can present with a large head. And S stands for a syndrome which is called as the Sotos syndrome. This is also a cause of large head, Sotos syndrome. Sotos syndrome is a overgrowth syndrome in children. So it's a type of a overgrowth syndrome in children and it is known to present with a large head. So if I ask you a question, can you name some important causes of large head in children? So repeat with me. Helens, HLNS, 3H, 2L, 1N, 1S. Which are the 3H? First, hydrocephalus. Second, hydranencephaly. Third, hemorrhage, bleeding in the brain. Then 2L, first leukodystrophies such as Alexander's disease, Canavan's disease. Then lysosomal storage disorders such as Tay-Sachs disease. Then N, neurocutaneous disorders or neurocutaneous syndromes. CNS involvement also, skin involvement also, such as tuberous sclerosis. And S, Sotos syndrome. So repeat with me once again. Helens, HLNS, important causes of large head. Hydrocephalus, hydranencephaly, hemorrhage, leukodystrophies such as Alexander's, Canavan's, lysosomal storage disorders, neurocutaneous syndromes such as tuberous sclerosis, Sotos syndrome. Very easy. Just repeat with me once again. Large head causes, Helens, HLNS, hydrocephalus, hydrancephaly, hemorrhage in the brain, leukodystrophy such as Alexander's disease, Canavan's disease, lysosomal storage disorders, neurocutaneous syndromes such as tuberous sclerosis, Sotos syndrome. So anytime a child with a large head comes in the OPD, outpatient department, you should immediately have these causes coming to your mind. And the diagnosis will be among these causes only. Similarly, we have some important causes of microcephaly in children. Some important causes of microcephaly in children. Microcephaly, as I told you, is a small head. Important causes of microcephaly in children. So one of the important causes of microcephaly in children is trisomies. So chromosomal disorders such as trisomy 13, trisomy 18, trisomy 21, they all cause microcephaly. So they have small head. Children with Down syndrome, children with Edwards syndrome. Edwards syndrome is trisomy 18. Down syndrome is trisomy 21. Patau syndrome is trisomy 13. So all these trisomy disorders in children can present with a small head. Their brain does not grow properly. So their brain remains small and therefore the head remains small. Then another important group of disorders in hydrocephalus, will there be macrocephaly after fusion of sutures? No. Once the sutures have fused, then a hydrocephalus will not present with macrocephaly. Then obviously it will present with other signs and symptoms which suggest raised intracranial pressure. So it's a very good question. Will there be an increase in the head? Please remember these microcephalies and macrocephalies, all of them is always before the sutures have fused. That is the time when head can either become large or head can become small. But when the sutures have fused, then obviously the head size cannot change. So these are all causes before the sutures have fused. And the second is most common cause among these. Well, it's very difficult to tell because there is no book telling which is the most common causes among the macrocephaly causes. But I think if you have to answer one, it should be hydrocephalus. Probably is the most common among all the causes of macrocephaly. Torch infections. Congenital infections such as torch infections, toxoplasmosis, rubella, cytomegalovirus, herpes. These are also important causes of microcephaly in children. So congenital CMV, microcephaly. Congenital rubella, microcephaly. Congenital syphilis, microcephaly. Even sometimes congenital toxoplasmosis. Toxoplasmosis can present with the hydrocephalus also, but can present with a microcephaly also. So these congenital infections again can present with microcephaly. Then a very important cause of microcephaly, HIE, hypoxic ischemic encephalopathy. So when the brain of the child, a newborn's brain, gets damaged because of lack of oxygenated blood supply, a newborn's brain is damaged because of lack of oxygenated blood to the brain. This condition is called as HIE and it can present with a small head. Don't worry, we'll discuss about it in neonatology in detail. So I'll discuss about HIE in neonatology in detail. Then another very important cause of microcephaly is fetal alcohol syndrome, and fetal hydantoin syndrome. fetal alcohol syndrome and fetal Hydantoin syndrome. So fetal alcohol syndrome occurs when mother takes alcohol during pregnancy, and fetal Hydantoin syndrome occurs when the mother takes phenytoin, anti-epileptic drug, in pregnancy. So taking teratogens such as alcohol or phenytoin during pregnancy, the fetus can get affected with multiple malformations. And one of those malformations is a small head, microcephaly. Sutures fuse at what age? Do not worry, I will tell you when I will be doing neurology. So don't worry about when sutures fuse. That I will tell you when we'll do neurology. A very important syndrome, Rett syndrome, is a cause of microcephaly in children. Very, very important syndrome. It's very, very important for your exams. Rett syndrome. In fact, this year in INI-CT, you had a question on the approved drug, recently approved drug for Rett syndrome. So Rett syndrome is a X-linked dominant disorder, and it only affects girls. Usually the manifestations will not be seen in boys. It's an X-linked dominant disorder which affects girls, and it occurs because of MECP2 gene mutation. So mutation in which gene? Mutation in which gene is associated with Rett syndrome? It is mutation in MECP2 gene. It's an X-linked dominant disorder. So obviously boys will never be affected, because if boys are affected, the boys will not survive. Boys have XY chromosome. So if there is an abnormality on X chromosome, the other chromosome is Y. So the boys will not survive. Girls have XX syndrome. Sorry, XX karyotype. So even if one X is affected, the other X, if normal, the girls will survive but will show manifestations of the disease. So Rett syndrome is only seen in girls. These children often have loss of purposeful hand movements. And these are replaced by involuntary hand wringing movements. So whatever purposeful hand movements the child is having, they are lost. So Rett syndrome is associated with loss of purposeful hand movements. So it's a type of a neurodegenerative disorder. What is meant by neurodegenerative disorders? Till a certain time, these children acquire milestones normally. But this is followed by regression, disappearance of the acquired milestones. There is one type of disorders, neurological disorders, in which milestones are acquired late. Sitting develops not at 6 months, but at 12 months. Standing does not develop at 9 months, but at 18 months. That group of disorders are cerebral palsies. All milestones develop later than normal. There is another group of neurological disorders in children which are called as neurodegenerative disorders. Here, till a certain time, the children acquire their milestones normally. After that, disappearance of the milestones happen. This is one such disorder. So, the speech of the child disappears. Hand movements of the child disappears. So whatever purposeful hand movements the child is having, that disappears, and it is replaced by involuntary hand wringing movements. It is replaced by involuntary hand wringing movement. This is a hand wringing movement. So it is replaced by involuntary hand wringing movements. These type of movements are signs of nervousness. So the purposeful hand movements in children disappear after a certain age, followed by appearance of involuntary hand wringing movements. Speech is also, whatever speech the child is acquired, also disappears. It is also associated, as I just now told you, with microcephaly and with intellectual disability. Mental retardation. Rett syndrome is the most common cause of mental retardation or intellectual disability in females. Please remember this. Rett syndrome is the most important cause of mental retardation or intellectual disability in females. In the DSM-5 criteria, we have now removed the term mental retardation because of the stigma associated with that term, the social stigma. We have now replaced mental retardation with the term intellectual disability. So if you are asked which is overall the most common cause of mental retardation or most common cause of intellectual disability in children, answer is Down syndrome. Most common cause of intellectual disability in children, but the most common hereditary cause of intellectual disability in children is not Down's but Fragile X syndrome. Down's is a genetic disorder, but it is rarely hereditary. It does not run in families. So if you are asked this question, most common cause of intellectual disability in children, mental retardation in children, answer is Down's, clearly. But if they ask, no, tell us which is the most common hereditary cause of mental retardation or intellectual disability, then it is Fragile X syndrome. Most common cause of mental retardation, Down's, but most common hereditary cause is Fragile X. But Fragile X syndrome is seen in boys. So that brings us to the question, which is the most common cause of intellectual disability in females. Now the answer is Rett syndrome. So if someone asks you which is the most common cause of intellectual disability in females, your answer will be Rett syndrome. So repeat with me. Most common cause of mental retardation or intellectual disability in children, Down's. Most common hereditary cause, Fragile X. Most common cause of intellectual disability or mental retardation in females is Rett syndrome. And recently there was a drug that was approved to improve neurological functions. So your May INI-CET exam had this question. This year INI-CET question was, which drug has been recently approved for improving neurological symptoms in females with Rett syndrome? So till now there was no drug that was approved for Rett syndrome. But based upon the data from a large clinical trial, there is recently a drug that has been approved for treating the neurological manifestations of Rett syndrome. And which is that drug? That drug is trofinetide. This was asked this year in INI-CET. Which drug has been approved for treatment of neurological symptoms of Rett syndrome? It is trofinetide. It was approved on the 10th of March 2023 by US FDA for the treatment of neurological manifestations in Rett syndrome. So which drug has been approved recently? This was asked in May 2023 AIMS INI-CET exam, and the answer is trofinetide. So just a few words which I'll repeat again. Rett syndrome, X-linked dominant disorder. Girls are affected, mostly boys, as I said, will not survive. Gene mutation, MECP2 gene mutation. Loss of purposeful hand movements replaced by these type of hand wringing movements. Microcephaly, intellectual disability and mental retardation in females. Most common cause of intellectual disability in females is Rett syndrome. Overall, most common cause of intellectual disability in children, Downs. Most common hereditary cause is Fragile X, but most common cause of intellectual disability in females is Rett syndrome. And which drug has recently been approved? It is trofinetide for the treatment of neurological manifestations of Rett syndrome. So causes of microcephaly in children: trisomy 13, 18, 21, important causes, then torch infections, hypoxic ischemic encephalopathy, fetal alcohol syndrome, fetal hydantoin syndrome, and Rett syndrome. And Rett syndrome, which drug has recently been approved? Trofinetide. So, what is the answer to this question? We'll be simultaneously doing 3 types of questions for you to have confidence that each chapter is covered properly. First, in between the text, when we are doing, we will be covering these type of questions. So in between the content of each chapter, we'll intermittently be doing these type of questions which you will be answering. Then each day we will start with a fresh set of questions, which will be a sort of a quiz in the morning. So tomorrow we'll have in the morning a quiz of around 20-25 questions, which will be from all the topics that we have studied today. Similarly, on the third day morning, we'll have a quiz of around 25 questions for all the topics, contents that you have covered on the second day. So that is the third. Then there is a last type of MCQs that we will do, which will be the previous year questions. When you will do those previous year questions, that will give you the strength and that will give you the confidence that whatever questions are asked in previous year questions, you have already covered them in your notes. So that should give you an extra confidence that now, yes, you can approach the pediatric questions with confidence. So as you can see, this is a question of a 6-year-old girl who is being evaluated with history of normal initial growth and development, followed by loss of purposeful use of hands, distinctive repetitive hand movements, seizures, and intellectual disability. The child has a small head. So the child has a microcephaly. On anthropometric measurement, the most likely diagnosis is Rett syndrome. So this is the question that has been taken from your guide. So it's a previous year question. And it is a typical history that you will expect in a Rett syndrome. There is another question on routine anthropometric measurement of a child during the grand rounds in a hospital. The head measurement of a child is found to be less than 3 standard deviation. So the child's head circumference is less than 3 standard deviation. So this is a microcephaly. Now he's asking the interns watching the case should expect all of these disorders in the differential. So which of these is not a cause of microcephaly? So which of these is not a cause of microcephaly? Fetal alcohol syndrome is a cause of microcephaly. Rett syndrome is a cause of microcephaly. Down syndrome is a cause of microcephaly. Sotos syndrome is not a cause of microcephaly, but a cause of macrocephaly in children. So these are the type of questions which I think you should expect for your exams. And I would just like to revise the things that we have already covered. Just let me revise the things that we have already covered. So I'll be asking you a few questions. I'll be asking you a few questions from the topics that we have already covered. Whenever I ask you those questions, please do not see your notes and answer. Let this be type of recall for you. trying to remember the things that we have already discussed in the last few topics. So we started today's morning by discussing about different age groups through which the child passes when he's growing. Then the sequence of puberty in boys, sequence of puberty in girls. Then we discussed about the growth assessment markers, weight, height, head circumference, mid-arm circumference. Then we discussed about the causes of macrocephaly, causes of microcephaly in children. So can you tell me what is normal value of mid-arm circumference? So let me see what is the normal mid-arm value for mid-arm circumference. Suppose your question is in the exam, what is normal mid-arm circumference in children? What will be your answer? What is the normal value for mid-arm circumference, which indicates a normally growing child? What is the normal value? Very good. So this is answer is more than 13.5 centimeters. But if they ask you what is the normal value for mid-arm circumference according to the Shakid's tape, according to the Shakid's tape, what is normal mid-arm circumference value? Then your answer should be more than 12.5 centimeters. So please remember, normal mid-arm circumference more than 13.5, but normal mid-arm circumference according to the Shakid's tape is more than 12.5 centimeters. So normal is more than 12.5 centimeters. Okay. Now on a Shakid's tape, and I hope you are not going through your notes. Just remember based upon the recall. On a Shakid's tape, the yellow color indicates what? On a Shakid's tape, yellow color indicates what? Does it indicate a severe malnutrition? Does it indicate a moderate malnutrition? Does it indicate normal value? Or does it indicate a malnourished, severely malnourished child? So does a yellow color on a Shakid's tape indicate severe malnutrition, mild malnutrition, moderate malnutrition, or a normal child? What is yellow color on a Shakid's tape? Severe malnutrition, moderate malnutrition, mild malnutrition, or a normal child? Very good. So this is moderate malnutrition on a Shakid's tape. Very good. So moderate malnutrition on a Shakid's tape. Very good. Next question. What is the age group when a child is called as a toddler? What is the age group when the child is called as a toddler? Don't see your notes and answer. If you do not know the answer, don't answer. But do not see your notes and answer. I want to see whether you are able to recall whatever I have told you in the class. So what is the age group when the child is called as a toddler? So very good. So the answer is 1 to 3 years of age. 1 to 3 years of age. So 0 to 1 year, infant. First 20 days, neonate. 1 to 3 years, toddler. 3 to 6 years, preschool age. 6 to 12 years, school age. And 10 to 19 years is adolescent age. Very good. The next question is, which is the fastest growth velocity period? Which is the fastest growth velocity period? Your choices are, is it the intrauterine life? Is it the adolescent period? Or is it the infancy? Which is the fastest growth velocity period? Is it the intrauterine life? Very good. So it is the intrauterine life which is the fastest growth velocity period. So intrauterine life, this is number 1, followed by infancy, which is number 2, and followed by adolescence, which is number 3. Very good. Very good. Then what is the time when, so how much is the loss in weight? How much is the loss in weight in a term child? How much of weight is lost in a term child? So let me see what your answer is. How much of loss in weight is seen in a term child just after birth? How much is the loss in weight in a term child just after birth? Very good. So 5 to 10% is the loss of weight in a term child. 10 to 15% is a loss of weight in a preterm child. Term child regain their birth weight by day 10 and preterm child regain their birth weight by day 14. Next question. A child has a birth weight of 3 kgs. His weight is expected to be 21 kgs. At what age? A child's weight is 3 kgs at birth. His weight is expected to be 21 kgs at what age? So a child's weight is 3 kgs. It is expected to be 21 kgs at what age? Double the birth weight, 5 months. 3 times the birth weight, 1 year. 4 times the birth weight, 2 years. 5 times the birth weight, 3 years. 6 times the birth weight, 5 years. 7 times the birth weight at 7 years. So very good. The answer is 7 years is the time when the child's weight will become equal to the birth weight. So will become 21 kgs. Sorry. So it will become 21 kgs. Next question is increase in length. Increase in length between 2 to 12 years is how many centimeters per year? So between 2 to 12 years, increase in length in a child is how many centimeters per year? Very good. So it is 6 centimeters per year. So it is how much centimeters per year? It is 6 centimeters per year. Very good. So it is 6 centimeters per year. Another question. The head circumference of a child becomes equal to the chest circumference at what age? The head circumference of a child becomes equal to the chest circumference at what age? The head circumference of a child becomes equal to the chest circumference at what age? Head circumference of a child becomes equal to the chest circumference at 1 year of age. So head circumference is more than the chest circumference at birth. Remember, cephalocaudal growth. So head circumference is more than the chest circumference at birth. The head circumference becomes equal to the chest circumference at the age of 1 year. And which is the most common hereditary cause? Most common hereditary cause of intellectual disability in children. Which is the most common hereditary cause of intellectual disability or mental retardation in children? Hereditary cause. So which is the most common hereditary cause? Fragile X syndrome. Very good. Fragile X syndrome. Most common cause of mental retardation or intellectual disability is Downs. Most common hereditary cause is Fragile X, and most common cause of intellectual disability or mental retardation in girls is Rett syndrome. And finally, what is the gene mutation? Which gene is mutated? Gene mutation in Rett syndrome. So which gene is mutated in Rett syndrome? So which gene is mutated in Rett syndrome? Very good. MECP2 gene mutation. MECP2 gene mutation. So very good. So this is basically what I feel. If you are truly answering the questions without seeing your notes, this I feel gives me confidence that you have understood whatever topics I have taught you till now, and you are able to recall those topics when it is required. It is not only important to learn the topics, to make notes on the topics. It is also important for you to recall those topics when the time comes. There is no point of remembering the topics till the time your exam is there, and when the actual time comes during the exam to recall those topics, then you forget them or you're not able to recall them. So as of now, it appears that you are able to recall those topics. So the last topic that we will do before the exams, sorry, not before the exam, before the break, the last topic is short stature in children, and then we'll take a break. Yes, treatment is trofinetide. Very good. So the last topic before the break, short statures in children. Short stature in children are basically children who have a short height. Now, there are two important types of short statures in children. One is physiological short statures and one are pathological short statures. So let us remember short statures by making the table. So short stature is basically short height in children. There are two types of short statures in children. One is physiological short statures and the second is pathological short statures. So there are two types of short statures in children. The first type of short stature in children is physiological. The other type is pathological. Now, as the name suggests, physiological short statures means there is no abnormality associated with short stature, which means the child does not have any underlying diseases, pathologies. So the growth velocity of children during most parts of childhood in physiological short stature is normal. What is growth velocity? Growth velocity means how much height the child is increasing every year. What is growth velocity? How much height the child is increasing every year. That is growth velocity. So when the child is not having any underlying pathology, the child is increasing height normally every year during most parts of childhood, but still the child is short, then we call this short stature as a physiological short stature. But when the child's growth velocity is reduced, that means the growth velocity of the child is less than normal. Growth velocity of the child is less than normal, reduced. Whatever height normal children are increasing every year, these children are increasing less height every year. And there are also underlying pathologies, diseases, which are causing short stature. That type of short stature is pathological short stature. Physiological is physiological because there are no underlying diseases. There are two types of physiological short statures. One is known as familial short stature and the other is known as a constitutional delay. So there is one type of short stature which is called as a familial short stature. There is another type of short stature which is called as a constitutional delay. And both of them, mind you, are physiological. That means there are no underlying diseases. In pathological short stature, you will see many underlying diseases causing short statures. Here, there are no underlying diseases. A familial short stature is usually a short stature. A familial short stature is usually a short stature, which is because of short parents. So the parents of these children are short. It is because of short parents. Please try to understand what I am saying. In familial short stature, in the first 2 years, the child grows slowly compared to normal. So in comparison to other normal children, a child with familial short stature will grow slowly in the first 2 years. So while other children will be growing like this child in his first 2 years will fall below the normal growth curve. So other children are here, this child will fall below the normal growth curve. First 2 years, because he had short parents. And then he will continue to grow normally throughout. After 2 years, children with familial short stature continue growing normally till 18 to 20 years of age when growth stops. It's only in the first 2 years when the growth was slow. But because they are not able to recover that slow growth of first 2 years, their final height is short. Because they are not able to recover. First 2 years they grew slowly. After that they grew normally. But because of that slow growth in the first 2 years, they are never able to recover. So their final height is always short. And if you see their bone age is always equal to their chronological age. Their bone age is always equal to their chronological age. What is a bone age? Bone age is basically taking an X-ray and seeing the appearance of ossification centers on that X-ray. So you are calculating the age of the child. You are calculating the age of the child by seeing how many ossification centers have appeared on the X-ray. So that is a bone age. The only type of short stature in which bone age matches with the actual age is familial short stature. If you are asked this question, and you have been asked this question, it's a previous year question, but it's the only type of short stature in which bone age matches with the actual age. It's a familial short stature. One or both parents will be short. Final height will be short. And bone age of the child will be matching with the actual age. Constitutional delay is associated with a delay in puberty. So there is a family history of delayed puberty, plus these children also have delayed puberties. Now please try to understand the difference with familial short stature. Please just hear what I am saying. In familial short stature, first 2 years, the child was growing slowly, but then the child continued to grow normally. In constitutional delay, first year the child grew normally. First 1 year after birth, the child was normally growing. Between 1 to 3 years, the child's growth slowed down. So the child was below the normal growth curve. Between 1 to 3 years, the child's growth slowed down. Then the child started growing normally. So in constitutional delay, first 1 year growth was normal. 1 to 3 years, growth slowed down. After 3 years, growth was again normal. But the main difference comes during puberty. During puberty, children with constitutional delay grow faster than normal. So they're able to recover their height. In familial short stature, the child was never growing fast. In constitutional delay, the child starts growing fast. So these children are able to recover their height. So their final height in a constitutional delay is usually normal. Final height in a constitutional delay is normal. And in a constitutional delay, the bone age is less than the chronological age. Bone age is less than the chronological age. I'll repeat the differences between familial short stature and constitutional delay once again. In familial short stature, the child had short parents. Either one parent was short or both parents are short. First 2 years, the child was growing slowly. Then the child was growing normally. But because of the slow growth in the first 2 years, the child's final height always remains short. When I calculate the age of the child in familial short stature with the X-ray, bone age, the bone age will match with the chronological age. Chronological age means the actual age. In a constitutional delay, basically the gene of the child is such that the child in the first year grew normally, but between 1 to 3 years, growth slowed down. Their genetic framework is such that they have a slow growth between 1 to 3 years. After 3 years, they grow normally again. But during puberty, their growth accelerates. So they are able to recover that slow growth between 1 to 3 years. So in constitutional delay, the final height is normal. In constitutional delay, the final height is normal. That is why in constitutional delay, I'm not writing short stature. I'm saying constitutional delay. It's just a delay in reaching a normal height. And the constitutional delay, the bone age will never match with the chronological age. It will be less than the chronological age. So only type of short stature in which bone age matches with the chronological age is a familial short stature. Children who have pathological short statures, as the name suggests, they have underlying diseases. Physiological short stature, there were no underlying diseases. Pathological short stature, there are underlying diseases. Pathological short statures are divided up into two broad categories. Disproportionate short statures and proportionate short statures. Disproportionate short statures and proportionate short stitches. So why is that, sir, in constitutional delay? I think he's asking why in constitutional delay the bone age is less than the chronological age, because their puberties are delayed. Bone age always matches with the onset of puberty. So if puberty will be delayed, bone age will never be normal. Bone age will always be delayed. And if puberty is fast, that means appears early, precocious puberty, bone age will also be advanced. Please remember the general rule. Whenever puberty is delayed or is precocious, earlier than normal, bone age will never be normal. Bone age will either be late, delayed, or it will be advanced. In familial short stature, puberty comes on time. That is why the bone age is normal. But in constitutional delay, puberty is delayed. That is why bone age is delayed. Now, disproportionate and proportional. Now, how to differentiate? So, if there is accelerated growth during puberty, it's only accelerated growth during puberty. Please try to understand. Growth has nothing to do with puberty. Please try to understand. When I say accelerated growth, that means fast growth. It has nothing to do with onset of puberty. The puberty may appear late, but during that late puberty, growth may be fast. Please don't confuse. Puberty may be late, but during puberty, growth means how much height the child is increasing. Didn't I talk about growth spurt during puberty? It's just that growth spurt is more in children with constitutional delays. So their puberty is delayed, but when their growth spurt occurs during that delayed puberty, the growth spurt is more than that of other children. See here. This is a normal body proportion. Normal body proportion means the proportion of the upper segment to the lower segment. Upper segment to the lower segment. Why is it delay in puberty, sir? Because growth spurt is delayed. See, try to understand what I am saying. When I say delay in puberty is basically because of the fact that their genes are having so programmed, their genes are so programmed that in them puberties does not appear on time. Puberties appear slightly later than normal. So while in other children puberty will be appearing at 10 years, in these children puberty will be appearing at 13 years. It's written in their genes that they will be approaching puberty later than other children. Now, because their puberty will be later than other children, their bone age will also be delayed, because bone age matches with puberty. Now, during puberty, the growth spurt will occur. That growth spurt is more accelerated. That means the growth spurt will be more than that of other children, which is why children with constitutional delay will recover their normal growth. So don't confuse the two. When I say puberty is delayed, it's because it is written in their genes that they will have a later onset of puberty in comparison to normal. But when they will have later onset of puberty, at that time the growth will be more than other children. So they will recover their short height, and after growth stops in constitutional delay, the final height will be normal. Can I expect more or taller person in constitutional delay? No. Taller person is, please try to understand, taller person is if there was no previous delay in growth. So, sorry, previous slow growth. In constitutional delay, it's like 2 years there was slow growth between 1 to 3 years. Later it is fast growth in puberty. So final height is normal. It is not tall. You won't expect taller person in a child who is in his first, who is in a constitutional delay. You'll expect a normal size person. Now, see, understand here. So this is a normal child. This is a normal child. In a normal child, the upper segment to the lower segment ratio. So at birth, the upper segment to the lower segment ratio is 1.7. That means the upper segment of the body is more than the lower segment at birth. So this is a child who is normal. His upper segment is more than his lower segment at birth. This ratio then goes on decreasing because remember cephalocaudal. So initially the head and the trunk is growing faster. Later on the extremities start growing faster. So the child by 3 years has an upper segment to lower segment ratio of 1.3. By 6 years has an upper segment to lower segment ratio of 1. And between 7 to 10 years, the upper segment to the lower segment becomes equal. So when does the upper segment becomes equal to the lower segment? Upper segment becomes equal to the lower segment between 7 to 10 years. Now, if the child is short, but overall his body proportion is maintained according to age, we call the child as a proportionate short stature. But if the child is short and his body proportion is also not matching, why is body proportion not matching? Either the child is having a long trunk and short limbs. This is one type of body proportion. This is called as infantile disproportion. What type of disproportion is this? Infantile disproportion. These children compared to normal have longer trunk but shorter limbs. The second is another type of disproportion in which the child has shorter trunk and longer limbs. This type of disproportion is called as advanced disproportion. So there are two types of disproportion. Either the trunk is long, limbs are short. This type of disproportion is called as infantile disproportion. Or the child can have a short trunk but longer limbs. This type of disproportion is called as advanced disproportion. So when the child is a short stature but his body proportion is matching, we call it as a proportionate short stature. But when the child is short stature and has type of a disproportion, we call it as a disproportionate short stature. Disproportionate short stature can be infantile disproportion, where the trunk is long, limbs are short, or it can be an advanced disproportion, where the trunk is short, limbs are long. So when we talk about short stature in children, short statures can be disproportionate, proportionate. As I just now told you, disproportionate can be infantile disproportion, advanced disproportion. Now, what are the examples of disproportionate short stature? The examples of disproportionate short stature are CARS. Remember, disproportionate short statures, they go in their cars. It's an easy way of remembering disproportionate short stature. Disproportionate short stature, they go in their cars. So CARS are examples of disproportionate short stature. C stands for congenital hypothyroidism. A stands for achondroplasia. R stands for rickets. And S stands for spondyloepiphyseal dysplasia. Spondyloepiphyseal dysplasia. So when I say disproportionate short stature, disproportionate short statures can be infantile disproportion, when the trunk is long, limbs are short, or they can be advanced disproportion when this trunk is short, limbs are long. Please remember, causes of disproportionate short statures is CARS. Disproportionate short statures go in cars. Congenital hypothyroidism, achondroplasia, rickets. They all are examples of infantile disproportion. Which is the example of advanced disproportion? Spondyloepiphyseal dysplasia. So which are the four important causes of disproportionate short statures? Congenital hypothyroidism, achondroplasia, rickets, and spondyloepiphyseal dysplasia. Which are the examples of proportionate short statures? Now, proportionate short statures example. Remember, proportionate short statures, they go on their feet. I told you, disproportionate short statures, they go in cars. Proportionate short stature, they go on their feet. So, proportionate short statures, they go on their feet. So which are examples of proportionate short stature? F stands for food. So malnutrition. Is an example of a proportionate short stature. So children who are malnourished may go on to develop a proportionate short stature. Then endocrinal disorders. such as growth hormone deficiency. Then another E stands for extended or chronic diseases. Chronic diseases like celiac disease, like chronic kidney disease. These are examples of proportionate short statures. Malnutrition, proportionate short stature. Endocrinal disorders such as growth hormone deficiency, proportionate short stature. Extended or chronic diseases like celiac disease, chronic kidney disease, proportionate short stature. And chromosomal disorders such as Turner syndrome, Noonan syndrome, Down syndrome, and Prader-Willi syndrome. They are again causes of proportionate short stature. Turner syndrome, Noonan syndrome, Down syndrome, and Prader-Willi syndrome. So chromosomal disorders, which can also be associated with proportionate short stature. So if someone asks you, can you name important causes of short stature in children? Please remember, short statures can be divided up into two broad categories. Repeat with me. Two broad categories: physiological, pathological. In physiological, growth velocity is normal during most parts of childhood. Familial short stature, constitutional delay. Familial short stature, first 2 years, they grow slowly the normal. Then they grow normally, never grow fast. So their final stature will always be short. Their bone age always matches their chronological age because their puberty always is on time. Now, students are asking, what is the reason for constitutional delay? Constitutional delay is, it's written in my genes to be a constitutional delay child. So I have a genetic framework such that first 1 year I will be growing normally after birth. Between 1 to 3 years, I will be growing slowly. Now try to understand what I am saying. 1 to 3 years, I will be growing slowly. So I will drop below the normal growth curve in comparison to other children. I will be shorter. Then I will continue to grow normally till 10 years of age. So throughout childhood, I will be short. After 10 years, my puberty will approach later than normal. It's written in the genes. Because the puberty will be delayed, the bone age will be delayed, because bone age matches with the puberty. So bone age of these children less than the chronological age. Their bone age will be delayed because their puberties are delayed. So their actual age may be 15 years, but when calculated based upon the X-ray, it will come out to be maybe 10 years. So the bone age will be less than the chronological age. So till 10 years, they will remain short. But when the child enters into puberty, and they will enter into puberty late, they will have a growth spurt. Now here the growth spurt will be more than other children. So don't confuse. Puberty may be delayed, but the growth spurt will be more in comparison to other children. So they were short. So when their growth spurt will be more, they'll recover their height. They won't be taller. They will be having a normal height because to start with, they were short. So their final height will be normal. And because their puberties were late, their bone age will be matching with their bone age will not be matching with the actual age. It will be shorter than the chronological or actual age. This is overall the most common type of short stature in children. So overall most common type of short stature is constitutional delay. So this is overall most common type of short stature that you see in children. Constitutional delay is overall the most common type of short stature that you see in children. Pathological short statures, as the name suggests, now there are underlying pathologies, disorders. Two types: disproportionate, proportionate. Disproportionate, long trunk, short limbs, infantile disproportion. Advanced disproportion is short trunk, long limbs. Examples of infantile disproportion is CARS. So disproportionate short statures go in their cars: congenital hypothyroidism, Achondroplasia, which is a skeletal disorder. Rickets, again a skeletal disorder. They are examples of disproportionate short stature with infantile disproportion. And disproportionate short stature with advanced disproportion, short trunk, long limbs. Spondyloepiphyseal dysplasia. What are the examples of proportionate short stature? They go on their feet. So malnutrition, endocrinal disorders such as growth hormone deficiencies, chronic diseases such as celiac disease, chronic kidney disease, and chromosomal disorders. The four main chromosomal disorders associated with short stature: Turner's, Noonan's, Downs, and Prader-Willi. Can you please share how topics will be covered in these each days? That I will tell a little later. Please talk about the diseases right now. Can sickle cell disease be an example of proportionate short stature chronic disease? See, sickle cell disease will cause a short stature indirectly because there would be breakdown of the RBCs, there will be hypoxia. So from the very initial period of their life, these children will be hypoxic, they will not be able to grow normally. So yes, overall, because of chronic hemolysis occurring, they might be short. So that is an indirect mechanism by which they can be short. S comes under advanced. So have you understood? Congenital hypothyroidism, achondroplasia, rickets are infantile disproportion. Spondyloepiphyseal dysplasia is advanced disproportion. And proportionate short stitches, FEET. Malnutrition, endocrinal disorders, extended or chronic diseases, Turner syndrome. So any other thing that you have not understood, please give a thumbs up if you feel that you have understood the topic still here. You have been repeating with me, you have understood the topics. Any problem that you have, please keep on asking. But otherwise, whenever I'm repeating, please repeat with me. In my classes, when I'm repeating, I make the students repeat, chant with me. Unfortunately, in these online classes, you are not there in front of me, so there is a big gap where I cannot see you. You people can only see me through this image, so I cannot ask you people to repeat with. I can only ask you people on screen to repeat with me. Please keep on repeating with me. That's the best. My years of experience tells that this is the only best way to remember the things for your exams. You keep on chanting, keep on repeating, making notes, and believe me, you will have those things in your head and you will not forget them. So most of you say, yes, you have understood the things. So with this, we take a break. Very good. And after the break, we'll restart. So after 15 minutes of break, we'll start again. So take a 15 minutes break and we'll start again after 15 minutes.